This entry for the Clinical Toxicology series is about benzodiazepines. Not benzodiazepines in overdose, which is already covered along with other sedative hypnotics in another video discussion, but when we use benzodiazepines as an antidote, corresponding to Antidotes in Depth Chapter A26 in Goldfrank's Toxicologic Emergencies. The learning objective for this session is that you should be able to describe at least 3 scenarios in toxicology where benzodiazepines would be antidotal therapy. Now here's a figure that we've seen before, or at least we've seen figures depicting the same thing, of how benzodiazepines work at GABA-A chloride channels in the central nervous system. Benzodiazepines have a binding site in the pentamer that forms the GABA-A chloride channel, and when benzodiazepines are around, this increases the frequency at which these channels open, allowing chloride ions to rush into neurons, hyperpolarizing them, making them less likely to generate an action potential, and this produces an inhibitory effect on the CNS. The chapter then goes on to talk about peripheral benzodiazepine receptors, which are probably better called tryptophan-rich sensory proteins, or TSPOs, since they're found centrally too. But the main clinical effect of benzodiazepines is CNS inhibition. In acute care settings, which is what we're focusing on in this course, benzodiazepines are used to treat seizures, whether toxin-induced or not, psychomotor agitation, which can be from other drugs with psychostimulatory effects, and withdrawal from sedative hypnotic drugs. On this slide, I've shown the big 3 benzos you're likely to see used: diazepam, midazolam, and lorazepam. And here's a better idea of their relative potencies, where you'd get roughly equivalent effects from 5 mg diazepam, 2 mg midazolam, and 1 mg lorazepam. In clinical settings, these drugs are often called by their common trade names of Valium for diazepam, Versed instead of midazolam, and Ativan instead of lorazepam. Some other toxicologic indications for using benzodiazepines as antidotes are for chloroquine overdose and for cocaine-associated chest pain. Using benzos for chloroquine overdose comes from clinical toxicology experience, particularly from France, where there have been publications giving instructions for using chloroquine to commit suicide, and treatment protocols using benzos seem to work favorably. With cocaine-associated chest pain, and probably with other psychostimulants too, benzos can help to reduce central sympathetic output. And both of these indications may also involve TSPOs, the peripheral benzodiazepine receptor 2. In emergency situations, which again we are intentionally focusing on here, benzodiazepines should be given IV. However, psychomotor agitation may be severe where it's difficult or impossible to get an IV. And if you have to use intramuscular drugs, then midazolam is the preferred agent. Also, note that the pharmacokinetics of lorazepam are slower. Lorazepam might be your best option to treat seizures, but it takes longer for peak effect, so it would not be ideal for rapid control of psychomotor agitation. Sometimes patients will be getting multiple repeat doses of benzos, or even be placed on a benzodiazepine drip. And with some benzos, these patients are at risk of developing lactic acidosis, particularly if they have underlying renal insufficiency, due to buildup of the propylene glycol in the drug diluent, which is metabolized through the same enzyme system used for ethanol from propylene glycol into lactic acid. This may explain why a patient in the ICU is developing a metabolic acidosis. We always think of shock and sepsis, but it may be from the meds. That's it from me about benzodiazepines. I'll be seeing you around.